For this morning, I'm very pleased to welcome you to the Cardinal Health sponsored symposium. And here we welcome Lorena Baccaro and also Emma G, both from King's College London. Lorena is the VTE Prevention clinical nurse specialist at King's College Hospital and enjoys both the clinical and VTE prevention role. This morning, Lorena is going to discuss venous thromboprophylaxis measures in the UK, best practice and clinical outcomes. And so I'm with pleasure passing over to you.
Thank you very much, Jo. Good afternoon, everyone. I'm glad to be part of the Thrombosis UK week and very thankful to Jo for organizing this. Very well done. We've heard quite a lot of good feedback from the team and everyone who's tried and joined in and seen the join the activities. And also I would like to thank Eleftheria and Cardinal Health for inviting me to present about venous thromboembolism or venous thromboprophylaxis measures in the UK, the best practices as well as the clinical outcomes. So before we go into what are these thromboprophylaxis measures, I'd like to have a look back on give you a brief history on how VTE prevention was integrated in the UK's health system. So sadly, it was the death of a 28-year-old female who flew in from Sydney to London following a 20-hour flight and eventually died with a PE that steered or evoked media attention in the UK. But they focused merely on travelers' thrombosis, and there was less emphasis or less awareness was made to hospital-associated venous thromboembolism. So this frustrated some other health professionals, and because of this, a group of health professionals formed a charity aimed at increasing awareness and funding for research about thrombosis. And eventually they met with the committee in the House of Commons to highlight the issues surrounding VTE and pointed out that about 50% of the VTE related deaths in the UK were due to hospitalization. And in 2005, the House of Commons Select Committee cited evidence that many deaths would have been avoided if patients had proper risk assessment and appropriate thromboprophylaxis would then be provided or administered. And it was then that the National Institute for Clinical Excellence, or NICE, was commissioned to produce a thromboprophylaxis guidelines for all hospitalized or admitted patients. As a result, in 2007, the first NICE guidelines on thromboprophylaxis was published. And 2 years later, a financial incentive for hospitals to focus on VTE risk assessment and prevention through the CQUIN, or Commissioning for Quality and Innovation. At that time, the payment for acute providers were conditional on risk assessing at least 90% of all admitted adult patients monthly. And this ensured compliance and monitoring. Eventually, the goal was increased from 90 to 95% 3 years later. And in 2014, the VTE prevention has been well embedded in the NHS and included in the contract or standard contract. So the CQUIN was stopped. And in 2010, with the National VTE Prevention Program was established in England, following we know that VTE is a significant cause of morbidity and mortality. And it's mainly aimed to reduce morbidity and mortality related to potentially preventable venous thromboembolism, may it be DVT or PE. And since it has been established, there's a significant reduction, about 20% of VTE-related deaths. And the foundation of the programs is the mandatory risk assessment, which involved documented evaluation of the patient's risk for both surgical and medical patients with significant reduction in mobility. A single factor for VTE in surgical or medical patients with significant amount of or significant reduction in their mobility is considered to be high VTE risk. And for those with high VTE but low bleeding risk, an anticoagulant thromboprophylaxis is advised, whereas mechanical thromboprophylaxis is indicated for those with high VTE and high bleeding risk. Medical patients without reduction in mobility and no other risk factors are considered to have low risk of VTE, and early mobilization and adequate hydration is advised. Apart from this, other supporting resources were created during the program, such as the VTE Exemplar Centers Network, which is composed of hospitals with established VTE prevention program and are also able to provide leadership and in terms of VTE prevention and support to those non-exemplar centers with regards to good VTE prevention practices, and are also involved in research on thrombosis. Currently, we have about 40 exemplar centers around the country. Another supporting resource was the National VTE Prevention Program, or website rather, where it provides a vast amount of resources, may it be for guidelines on risk assessment, patient information leaflets, as well as links to the VTE. It's now called VTE Specialist Network, formerly known as the National Nursing and Midwifery Network, and to the anticoagulation and thrombosis group. So these groups provide support and share resources on how, or their guidelines and their best practices in terms of VTE prevention. Also, an e-learning resource was created, which I believe is still nationally used to aid health professionals, may it be doctors, nurses, healthcare assistants, any other members of the healthcare team, to learn the importance of VTE prevention, how to risk assess, and which appropriate thromboprophylaxis to administer or provide. Despite the establishment or the VTE prevention being embedded in the NHS framework or NHS standard contract, it has been noted that there was a significant decline in terms of risk assessment. So in 2019, GIRFT, or Getting It Right the First Time, which is a national program designed to improve medical care within the NHS by reducing unwarranted variation in clinical care, did a thrombosis survey, and it ran from around, sorry, there's thunder going on. It was launched in 2009 and it was extended up to 2020 following the COVID-19 pandemic, and it's also to capture COVID-19 related thrombosis. And since the GIRFT thrombosis survey was started, it aimed to look at the potentially preventable thrombosis or events and identify best practices among NHS trusts in England. And after the completion of the survey, they've made some recommendations, but I will only talk about few of the things that I think it's that we need to highlight on today, but these are not limited to these alone. So the first recommendation was the development of a VTE prevention role for those hospitals without an individual who is signposted to do the role, and also to liaise with the exemplar centers and to form a body system to ensure that 95% risk assessment is being met, as well as sharing best practices or guidelines. Also, it was recommended to routinely identify hospital-associated thrombosis to ensure patient safety and good practice. And it was noted that there's variation among the different NHS trusts who participated. Some use death certificates to identify VTEs, some will use radiology reports, manually checking positive and negative ones, and use other system. And they've also highlighted to develop improvement or quality improvement projects for inappropriately missed thromboprophylaxis. The survey found that it was very common, about 8%, that omissions happen or in practice, and this composed about 20% of hospital-associated thrombosis. And it was highlighted also to improve patient information, may it be written or verbally. And they found that this requires improvement. Currently, personally, I would admit this remains a challenge, as we are trying to be more creative on how we promote awareness as well as engagement from the patient and our service users. In the trust, we have developed a patient information video apart from the written information leaflets, but still there's a lot of encouragement that we need, or education as well, that we are trying to implement in practice, especially those who are at bedside or giving bedside care. And lastly, they recommended the review and use of anti-embolism stockings for medical and obstetric patients, given that there was a lack of recommendations from NICE and lack of evidence regarding the prevention of VTEs with the use of stockings. As far as I'm aware, there's ongoing discussions with GIRFT and the National Health Service Executive for a second GIRFT survey to look at the practices and what further improvements can we make, but it's still an ongoing discussion. For the mechanical thromboprophylaxis, as we know, we give out chemical and mechanical. We currently use anti-embolism stockings for mainly in the trust. We use them for surgical patients with emphasis mainly on measurement and documentation, especially with skin evaluation daily. With intermittent pneumatic compression device, as per the recommendation from NICE and following the CLOTS-3 trial, they are used for stroke patients, and we administer or provide them until the patient is back to its baseline mobility, or at least 30 days when they are completely immobile. But also we highlight to monitor the compression or the therapy time. It's not been studied in the UK yet, but I believe in the US, they've found that with this intermittent pneumatic compression device, patients must have at least 18 to 20 hours of therapy for them to get the benefits of clot prevention. With the chemical thromboprophylaxis, based on GIRFT, 8%, about 8% of chemical thromboprophylaxis were inappropriately missed or omitted without clinical reason. Hence, we always emphasize that when patients refuse, their reason or exploration should be done as to the reason why they're refusing, and also to escalate it to the senior members of the team to establish whether patients have the capacity, and also to allay fears or clarify confusion, as well as eventually identifying other or alternative thromboprophylaxis. And we've coined this acronym words to ensure that patients or chemical thromboprophylaxis are administered appropriately. So to ensure that weight is done for those, because our trust uses weight-based dosing with the chemical thromboprophylaxis. Some operations or procedures does not require chemical thromboprophylaxis to be omitted. So we highlight that as well, and ensure that risk assessments for VTE are documented. Apart from being done, it must be documented, and to ensure that the drug is checked with another registered nurse to ensure that it's the correct dose and that it's appropriate for the patient. Also, we highlight that if the patient's going for procedures or operations that are either delayed or cancelled, to ensure that they are reassessed for VTE and their thromboprophylaxis are or should be represcribed as appropriate. So the data shown here is taken from the King's College Hospital Denmark Hill site. And this is just to give you a picture on the current situation we have about hospital-associated thrombosis. So this covered April of last year up to March this year. And it showed we had about 300 hospital-associated thrombosis, and about 4% of that is potentially preventable. As a major trauma center, the common themes include, most of them, about 38% of all the hospital-associated thrombosis, the potentially preventable ones, have contraindication to receive chemical thromboprophylaxis. Either they have an active bleeding or they have high risk for bleeding. About 24% has been given correct thromboprophylaxis, no missed doses, but still developed VTE. We have about 10%, that's about 27 patients that received inadequate thromboprophylaxis. So this could either be due to the incorrect dose of enoxaparin or the chemical thromboprophylaxis, but also complete omission or not given any thromboprophylaxis at all. And the rest are line related and some were unexpected. Since we have touched on the ideal practices, I'd like to present some real VTE scenarios. And the first one involved a 49-year-old male who was transferred from another hospital, and he was admitted during, he was intubated during admission. He had incision and drainage in theater for a submandibular access. He was risk assessed during admission, and he was prescribed both chemical and mechanical thromboprophylaxis. However, a few days later, when he was transferred to or stepped down to the ward, the risk assessment was done, and he was then assessed as low VTE risk, given that he was able to mobilize. Clinical notes upon review have shown that he's not completely back to baseline mobility, and he's a surgical patient with an ongoing infection. 6 days later, he was taken to theater for a washout of the abscess. It was both intra and extraoral approach. But the clinical documentation sadly stated no worries for VTE, quote unquote, as patient is mobile, and no thromboprophylaxis was prescribed. 5 days later, total of 11 days since he was admitted, he was diagnosed with bilateral PE. So what can we learn from this? I think what I'm trying to highlight in this scenario is that VTE risk assessment can sometimes be subjective. And this patient, because he's mobile, they thought that, and the procedure was done on his on the upper part of the body, so he's not completely immobilized. So he was assessed as low risk. However, it is important to note that this patient had surgery twice actually, and I didn't mention it up there, but the total anesthetic time was about an hour or 60 minutes. And also he has ongoing infection. As we mentioned, or the risk assessment, the national tool for risk assessment, if you are surgical patients with other risk factors, ongoing infection, procedure, as well as previous critical care admission, he should have been given thromboprophylaxis. So correct risk assessment is vital for us to be able to prescribe and administer appropriate thromboprophylaxis. The next scenario is about an 85-year-old female who presented with a right facial droop and left-sided neck swelling. She's known to have atrial fibrillation, but she was not given or she was not anticoagulated because of a previous upper gastrointestinal bleed. She was not weighed on admission, or at least there was no documented weight on admission, but she was risk assessed for VTE, and it was they've assessed her as high risk for VTE but low bleeding risk. So they prescribed enoxaparin 40 milligram once a day, and there were no missed doses. A week later, she's had her weight recorded as 121 kilograms. So then they've changed the dose because of we use the weight banded enoxaparin or chemical thromboprophylaxis. So it was increased to 80 milligram once a day. 17 days after she's been admitted, she was found to have bilateral pulmonary embolism and bilateral deep vein thrombosis. So while some might argue that NICE didn't make any recommendations on weight-based dosing for thromboprophylaxis, but based on the GIRFT survey, about 82% of the participants use weight-based dosing. And here at King's College Hospital, we use weight-based dosing. And the example above showed that the patient received inadequate, although it was given and there were no missed doses, it was inadequate based on her weight, resulting in bilateral PE and DVT. So the learning I wanted to highlight here is that in the practice, we've relied quite a lot on estimated body weight, and sometimes, or most of the time, this puts patients at risk of developing VTE in view of not receiving adequate or appropriate thromboprophylaxis. Feel free to ask questions. You can put them in the chat should you have any questions or reactions. Moving on, I guess the VTE prevention is complex, and there is varied practice and definitely more to learn and discover. And we are quite lucky in the country because we have really intelligent and driven individuals or group of individuals who are into research and innovations in terms of clot prevention. I know there's quite a lot, but I think I'd like to highlight some of the interesting research that has happened or has been done and are still ongoing. First one is the PETS trial, or it stands for Prevention of Venous Thromboembolism in Low-Risk Surgical Patients. And it's aimed at examining the potential benefits of the anti-embolism or the graduated compression stockings in patients with short stay surgical procedure and are assessed as low-risk VTE. So it would be interesting to know, because currently in practice, for them who are day case and are assessed as low risk, we don't normally administer or prescribe anti-embolism stockings. So it would be very interesting to know what will be the outcome of this research. The next one is GAPS, which stands for the graduated compression stockings as adjuvant to pharmacothromboprophylaxis in elective surgical patients. This research concluded that the administration of pharmacothromboprophylaxis or chemical thromboprophylaxis is non-inferior to a combination of the anti-embolism stockings as well as the chemical thromboprophylaxis. So you might say like, oh, so in practice, why are we still giving stockings and chemical thromboprophylaxis at the same time? I think some will argue that they're more, there is still data about supporting the stockings for surgical patients, but at the same time, some of them will feel more confident, especially for those surgical patients. Also, there's a national VTE app being developed following the GIRFT report that showed that among the participants, there is variation in provision of patient information surrounding VTE prevention, and only 30% of the participants confirmed that they are providing patient information. And hence this study or this app is aimed to bridge the gap and make information about VTE and methods of prevention more accessible to patients, especially now that we are more in the technological side of things. And I'm sure you've heard about the UK trend. It stands for UK Thrombosis Research Network. And this is a clinician-led network of healthcare professionals that are interested in thrombosis research and are currently recruiting for interested professionals. I believe the session was done about this, so I will not dig deeper into the details, but you can look it up as well if you are interested to join. I would, apart from the VTE or DVT and PE being the major cause of mortality and morbidity, it can also be very traumatic. And a paper written by Hunter et al. Examined the psychosocial effect of VTE. And the data have shown that physical and psychological challenges of patients having the first-hand experience of VTE. Also, the patients have reported that their lives have somehow reports or being changed forever because of the experience. Some of them have continued episodes of panic, stress, the fear of having another clot, and the negative emotions that the worry of developing one or dying from a clot has impacted their relationship with families, their job, and their lifestyle in general. So the distress following a DVT or a VTE is real, and that we can, in our own respective areas, provide support to these patients. I believe during the study, they've provided counseling and reviewed the patients regularly, but they've only sampled quite a small number of participants. But this happens in real life. And as they say, prevention is better than cure. Hence, we can all work together in providing awareness and improvement or improving our VTE prevention strategies. So where do we go from here? We have VTE prevention measures or VTE prevention guidelines. And the NHS in general defines the quality of care, includes these three dimensions here: clinical effectiveness, patient safety, patient experience, and patient safety. And one can argue whether the VTE prevention role is still relevant since it's already embedded in the NHS framework. And personally, I think it still is. VTE remains a safety issue, and it is important to acknowledge that suboptimal practices were observed by those who do not have any designated individual in the role, as well as having someone who is motivated and is focused on the improvement of the delivery of care and good practices. I think VTE prevention role is still and will still be essential in sustaining good practice and the delivery of quality healthcare. I think that's it for me. Thank you very much for your attention and spending some time and lending us your attention today. I would like to thank again Eleftheria from Cardinal Health for inviting me to talk and be in this symposium, Joe for organizing and doing a brilliant job. And I would like to welcome everyone if you would like to ask any questions.
Thank you so much, Lorena. That has been so interesting. And I think what you've ended on about VTE is still a priority and prevention is better than cure at the end, really resonates, because yes, the damage, whether it be physical, so pain, harm to the veins, the psychological effect, and also the ongoing considerations that anyone who's had a blood clot has to then make in their as they continue through life. So for a woman, that could be around contraception, having children, hormone replacement therapy. For others, it can be around work, travel. And certainly this week, we've shared a story on somebody who's really felt he had to change his job. He needed to keep active because it had such an impact on him with a young family. So yeah, prevention is critical. And that's, I know, what the NHS leads and the exemplar centres are working towards as far as possible. But often in a hospital where everybody is under so much strain, and other medical centres, implementation can be very difficult. Have you found in your own centre things that have really helped? So for instance, in helping colleagues to understand why this risk of assessment is so valuable, so either in training or the way it's performed or who it's performed, have there been any things that have progressed it on well for you in your centre that might help others?
Yes, since I've started the role, I've actually sort of looked into the areas who are having issues with their risk assessment scores, because in the trust we evaluate each ward, each specialty monthly, and we look at how they're performing, whether they're up to the standard, meaning risk assessments being done 95% and above. And we've noticed that, one, there's lack of awareness. Some clinical or health professionals that come from other trusts or are newly qualified don't have a vast amount of knowledge in terms of VTE prevention. So education and training really helps. May it be how to do risk assessment and how to complete them, and which appropriate thromboprophylaxis as well. And we found that when we implemented teachings, visiting them on the wards, including e-learning resource to their induction or their training, has really helped improve their confidence in risk assessing as well as prescribing the appropriate thromboprophylaxis.
Just to add to that, if I may as well, thanks, Irina. I think that it is an ongoing challenge and it's an ongoing task, this education with staff turnover and also the other competing really important risk priorities that exist for our patients who are hospitalized. What I've found really helps in the past is actually trying to bring VTE to life, because I think what we found actually was that when we mentioned VTE to clinical, particularly ward staff, they immediately thought that we were talking about the VTE risk assessment, which has started to become referred to as the VTE. And we just wanted to make sure that people really understood what it's like for patients when they do get a blood clot and some of the ongoing effects they can have, such as post-thrombotic syndrome, risk of recurrence, CTEPH from PE, and all of the psychological issues and social issues that some of them go through that Lorena has already mentioned. And I think that that is a thing that helps to sort of win over people in order to see the VTE risk assessment as not just a tick box exercise, but actually really important work in preventing all of these horrible things that can happen to patients. But like I say, that's why I think it's important to have VTE prevention leads in hospitals, because it's ongoing. It's not something that you can do once and then that's job done. It's going to need to be sort of little and often, I think, probably always.
I totally agree with you both. And as you say, with turnover of staff and often the VTE risk assessment in some centres falling on the junior doctors who also change roles and move on, it is that ongoing work that's required. On another front though, when you showed your audit, do you also feed back and do further training or follow up either around audit on that and potential avoidable events, or on compliance to perhaps the mechanical thromboprophylaxis and how it's being used, put on, etc.?
Yes, it's every time that we do audit, we actually, or every time that I do investigate and do audits, I actually email, if not go to the ward or feedback to their managers and provide adequate or supportive training to where we're lacking, especially those that are potentially preventable events. And sometimes the very common thing is just these are little things that we sometimes overlook just because it's not part of the priority, or sometimes due to clinical pressures as well. But I believe we have more than qualified individuals, and I think it's just making them realize that they are capable and there is support if there are confusions or if there are any unclear information or training that they will require.
Thank you. Yeah, and I think you're right, all of that. And as you say, understanding the real impact can have a huge difference. Something very close to everybody's heart at Thrombosis UK is patient information. And you mentioned the film. Now I know King's have created this excellent short animated film, which is free to download for any centre to then implement onto their IT systems. And it's designed to share with inpatients so they can become aware of blood clots, of possible risk factors, of signs and symptoms while they're in hospital and then when they leave. Have you, two questions really, have you been able to audit or seen whether people have liked this format because it's a film format, or whether it's been helpful, whether it's stimulated conversations then, and also the benefit of talking to an individual about their risks or what they can do to reduce this? Have you been able to do any work on that?
The audit has not been completed. There is a plan, but I think what we are more focused on is to disseminate the information that it is available. The video is there. We've created like a poster that we've distributed to the wards to make it known to everyone, may it be patients, relatives, or our other service users, that the video is there. It is available for them to see. We use them for teachings for clinical health professionals just to highlight that it's there. But I find that verbal interaction with patients or service users does not replace the, although it's interesting to see a moving video, but the interaction, I find that the impact is greater, and that you engage with patients and you make them understand better why we're doing such things, why are we preventing, and that they have the resources and the support, which makes them very lucky because not everyone in the world has the equal amount of opportunity and service or given to them or being made available to them.
Yeah, and I think it's in all of our natures, isn't it, to know that if we talk with somebody about anything, we're more likely to at least make them more aware, if not persuade them, than if we just give them a piece of written or visual information alone. It's a whole combination, but talking, keeping them as a community, sort of an individual, listening to what's important to them and then sharing what could help them is critical in all of this. A last question really, and this is a really daft but practical question. One thing I imagine, and I know from a recent experience really, is that hospitals are really busy, such as King's, huge areas. And in one of your case studies, you mentioned, somebody hadn't been weighed. How do you overcome some of those practical issues? Because sometimes some of those tools aren't available, aren't on hand, are they? And that sets that chain of delay, which is nobody's fault. But how do you address this?
So we are quite fortunate that we, apart from us highlighting it to the team, we have other very motivated individuals on the ward. We have linked nurses, and most of the individuals are aware that weight is not only used for VTE prophylaxis. It is essential for really the care. Antibiotics need weight and all that. But what we do is that we look at whoever are the pharmacy team are very good at highlighting to the clinical team every day, like they do check and highlight that the weight needs to be done or needs to be documented. But at the same time, some wards have developed what we call as care bundle. so that they would have, let's say, for example, a set of things that needs to be checked and make sure that these are being done for patients, may it be oxygen status, their escalation status, or and weight is included to some of the wards. Although I would admit it still needs improvement, and with the ongoing pressures and with the quick turnaround of staff, I think there's still quite a lot of improvement to be done on that area. But as much as we can, we do try and remind them.
Lots of challenges, but as you say, linked nurses and lots of opportunities to potentially overcome some of those challenges. I know I, for one, was not quick to say, do you want to weigh me? But it was the one area that I wasn't keen. And just finally, and actually I'm really pleased, the film that you referred to earlier on as well, if anybody's interested, it did go out in the eShot yesterday. Oh, it went out this morning. It was done last night. So it went out this morning, so they can access it from there. And I know it's on the VTE Exemplar Centre website, as well as Thrombosis UK website, and they can just download it to use it, can't they? So that anybody who's attending here would have received that eShot, so they can access it, they can look and access it that way. Thank you so much. It's been a really interesting morning, lots of learning and lots of guidance as well, and tips. If anybody wants to get in contact with you, are you happy for that? And can they get in contact through the VTE Exemplar network as well?
Yes, please do. I'm more than happy to. They can email me or just contact through the Exemplar Centre.
That's brilliant. Thank you so much. And thank you to Emma as well, and to all of the audience who attended. And we'll see you in the next session. Thank you.